Hi guys, it's Brittany. We're going to start our cardiovascular classes with some PowerPoints. This first one is we're going to review the pathophysiology of both hypertension and dyslipidemia. We'll describe risk factors and treatment for both chronic diseases and describe the impact of patients from the FNP perspective. I've added some case studies and review questions throughout the PowerPoint. I've also uploaded all the PowerPoints so that you can print off to take some notes as we go along. If you have any questions, definitely be willing to answer those when we have our in-class meeting on the 29th of May. So here we go. We'll first start with hypertension. So hypertension is an elevation of the systolic blood pressure. There's still ongoing debate about appropriate goals and guidelines. We've actually had some new guidelines come out this year. It's a very common chronic disease. You're going to see this quite frequently within your practice. It's quite prevalent and increases to 65% in adults greater than the age of 60 years old. More common in African Americans, males at a much younger age. It's very costly. $46 billion are spent in healthcare services, medications, missed days of work. Many impact on other comorbid conditions. There's impact on lifestyle and making lifestyle modifications. And I think the most important part of this is the choices of antihypertensive medications that we prescribe, and we'll go through those throughout the presentation. So the pathophysiology of hypertension, there's 5 main components of normal blood pressure. It is very dependent on the balance between cardiac output and peripheral vascular resistance. We use the renin and angiotensin system. And you probably learned about this in your pathophysiology class. I'm not going to go through that in much detail here. Just remember the sympathetic nervous system stimulation can cause both arterial constriction and dilatation, and it's responsible for the changes in blood pressure in response to stress and physical exercise. The vasoactive system and mechanisms affecting sodium transport and vascular tone as a potential vasodilator that activates the angiotensin converting enzymes. And because of the system, that's why some of the medications that we use and prescribe, especially the ACE inhibitors, impact blood pressure. Other factors include insulin resistance, genetics, birth weight, and diastolic dysfunction, which is the relaxing of the heart muscle. Again, here's just a brief slide that shows the systems involved in the development and maintenance of hypertension. All 4 of these systems play an important role in the management of blood pressure. So JNC 8 recommendations are what we are currently using, and this is what you're going to be tested on. I provided a handout within the module for you to print out. I suggest that you memorize this. There's been many changes from JNC 7, and some of that is the goal systolic blood pressure and the first-line medications that we use. There's also guidelines for American Heart Association and the American College of Cardiology. They published guidelines in 2017. Some of these are very similar. The lower definition of hypertension is the treatment of hypertension with a systolic blood pressure goal of less than 130 millimeters of mercury. And this is kind of just, are working on tighter control of blood pressure. The other important part is not just treating patients with blood pressures in the office. Having patients do blood pressure measurements outside of the office is definitely now recommended. And we always want to focus the patient's cardiovascular risk and other diseases when choosing treatment goals. The American College of Physicians and the American Academy of Family Practice Physicians also published guidelines in 2017. Again, very similar to our other guidelines. We've just become more strict in our systolic blood pressure measurements. So hypertension treatment, you want to first make sure that the blood pressure is correctly documented. We have in our office our MAs. They we actually make them do manual blood pressure checks. And anytime that we have an abnormal reading, I, as the provider, will also check the blood pressure myself. You want to use arm cuffs. A lot of patients think that the wrist and finger readings are not as reliable. So I always ask patients when they're measuring their blood pressures at home exactly what tools that they're using. You definitely want to make sure that the cuff is the correct size for the patient, and make sure that you're taking the blood pressure on the upper arms. I've had some patients take their blood pressures on their forearms, which is not adequate. You want to measure the blood pressure in both arms if possible, and you want to take 2 to 3 readings separated by 1 minute in a seated resting position. I have patients many times do a 2-week blood pressure logs. I have the patient take the blood pressure twice a day and only twice a day. Sometimes when you tell patients to monitor their blood pressures at home, they like to take it 5 or 6 times throughout the day. Well, blood pressures are going to change throughout the day depending on what the patient is doing during that time. So I usually have them take it early in the morning and then at either right before bed. And I will have them write it down and send me those logs so I can correctly manage these patients. It's always good that to write a prescription for blood pressure cuffs. A lot of companies will pay for a blood pressure cuff for the patient at no cost. When you examine a patient with hypertension, again, you want a thorough history and clinical exam. Common complaints for these patients are ongoing headache, dizziness, lightheadedness, feeling foggy in the head. They can be very fatigued, irritable. They may have chest pain, shortness of breath with exertion, and lower extremity edema. Past medical history, you want to look for secondary causes, any history of sleep apnea and diabetes, family history of kidney disease and cardiovascular disease. Social history, you want to look at what is their stress level at their job or family situations, their level of physical activity, dietary choices, caffeine use, smoking, and alcohol use. And along with blood pressure recordings, you want to check heart rate and the patient's BMI. Ongoing examination for the patient with hypertension, you want to do a fundoscopy exam. You're looking for hypertensive retinopathy. You may see atrial constriction, vascular wall changes, flame-shaped hemorrhages, cotton wall spots, or yellow hard exudates, and possible optic disc edema. When you're looking at EKGs, you may notice left ventricular hypertrophy, which is shown with a QRS that's slightly widened and a left axis deviation, along with some ST depressions, inverted T waves, deep S waves, and elevated R wave amplitude. And we'll go into further into this when we talk about our EKG lectures. You can also do a urinalysis. You're looking for protein and hemoglobin. A basic metabolic profile is very important. You want to check electrolytes, specifically looking for patients' kidney functions. their BUN and creatinine. This will also help determine medication choices. You always want to get a TSH. A chest x-ray could be done if patients are having shortness of breath and lower extremity edema. What you're looking for is pulmonary edema and possible aortic dissection. And head CT if concerned about possible stroke from elevated blood pressures. Probably the most important part of the treatment of hypertension is lifestyle modifications. These include weight loss, dietary modifications, including the DASH diet and reducing sodium intake. I've included within your module some handouts that are good teaching material for your patients regarding DASH diet and reducing sodium intake. You want to have the patient increase their physical activity, smoking cessation, alcohol in moderation, and of course reducing stress. Many medications that we use for treating hypertension is thiazide diuretics, angiotensin converting enzymes or ACE inhibitors. We also have angiotensin receptor blockers. These are the ARBs. We have calcium channel blockers, beta blockers, and many combination of drugs and diuretics. We'll first start with the thiazide type diuretics. The mechanism of action is just to rid the body of water and salt. Things that you have to be careful about is electrolyte disturbances. You'll want to check a BMP after you have started these medications. Patients can complain of GI discomfort, rashes, allergic reactions, sexual dysfunction in men, photosensitivity, and orthostatic hypotension. You need to be cautious for patients that have an allergy to sulfa drugs. Just remember NSAIDs can reduce the effectiveness of these medications. Example of these meds is hydrochlorothiazide, chlorthalidone, and metolazone. Key points is to warn your patient that this medication will increase urination. You want to monitor patients' potassium levels. Watch out for dehydration. You need to cautiously use in elderly patients. And again, these medications may worsen lipids and glucose metabolism. ACE inhibitors. These cause vasodilation of the blood vessels, reduce the body from producing angiotensin II, exert some of the effect by blocking the bradykinin inactivation. Adverse reactions. The biggest complaint of these medications is a development of a cough. You have to be concerned about hyperkalemia, loss of taste, and in severe allergies, angioedema. Again, NSAIDs can reduce the effectiveness. Just remember African Americans and elderly respond less to ACE inhibitors. Example of these medications are the medications that end in pril, anapril, lisinopril, captopril, and ramipril. Key points to remember, again, monitoring the BMP after you start these medications, especially the potassium level. You also want to look at the liver enzymes. Do not give any of these medications to pregnant patients or patients that are still able to become pregnant. Next are the ARBs. These are a newer class of medications. Mechanism of action, it displaces the angiotensin II from the angiotensin I receptors, causing vasodilation of the vessels. Adverse reactions include dizziness. Again, some of these patients do also develop a cough. They can have severe diarrhea and again hyperkalemia. ARBs are very important to use in patients with known chronic kidney disease and diabetes. These are relatively safe in elderly patients. Examples of these are the medications that end in artin, losartan, valsartan, candesartan. Key points is, again, monitoring the BMP when you start. Some of the ARB medications, unlike the ACEs, these are BID dosing. So you want to keep that in mind when you're prescribing medications for patients that are not good about taking medications twice a day. Calcium channel blockers, again, mechanism of action inhibits the calcium channels in the heart and vascular cells. They block the smooth muscle dilators and have negative inotropic effect. Adverse reactions include dizziness, headache, significant lower extremity edema, worsening urinary incontinence, and constipation. Remember, calcium channel blockers also inhibit sinus pacemaker and AV conduction on some of the calcium channel blockers. So you need to watch for bradycardia, and if a patient already has an issue with AV nodal disease, you want to potentially avoid these medications. The one medication that does not affect the AV conduction is amlodipine or Norvasc. Calcium channel blockers also work for patients that have ongoing angina complaints. These medications can be given in combination with some statin medications. These are most effective for African American patients. There is an interaction with grapefruit juice, so you need to remember to warn your patients about that, or ask if they do drink grapefruit juice. Examples of these medications, again, they end in usually PINE. So we have amlodipine, diltiazem or cardizem, nicardipine, and verapamil. There are also some other medications that you will possibly see. However, if you're getting to the point that you have a patient on a thiazide diuretic, an ACE or an ARB, possibly a calcium channel blocker, you should be referring these patients to a hypertension specialist. Beta blockers do work not as well for blood pressure management, but you will see patients that are on beta blockers for their blood pressure. The central alpha 2 medications like clonidine, I would really reserve this medication if you have someone that's has been really intolerant to the other class of medications. A direct vasodilator that works well, and then that sometimes we use if a patient comes in and they're extremely hypertensive with symptoms, is hydralazine. There's other loop diuretics that we can use, such as furosemide or furosemide. But again, these medications, many times, you may see your patients on these medications, but if you're getting to the point that your blood pressure management is failing with the previous class of medications, I again would refer these patients on to cardiology or a hypertension clinic. Resistant hypertension is a blood pressure that remains above goal despite concurrent use of 3 hypertensives, or BP is controlled on 4 or more medications. This is elevated blood pressure that does not respond to the normal class of antihypertensives. This is ongoing systolic blood pressures greater than 180 or diastolic blood pressure over 120. These patients also, they may also complain that they've been on antihypertensive medications for many years, and now suddenly their systolic blood pressure is uncontrolled. Resistant hypertension is also a diagnosis given to sudden onset of elevated blood pressure before the age of 30. These patients more than likely have a secondary cause for their hypertension. Another key point is make sure that the patient has been compliant with their medications and taking their medications as prescribed. I've had a couple cases where the patients have been referred for resistant hypertension, and when I talk to the patients and go over their medications, they actually have not been taking their medication correctly. Again, if you have someone with resistant hypertension, you need to refer to a hypertension clinic. Secondary causes of hypertension. This is very important to keep in mind. You may, if you don't treat the secondary cause of hypertension, you're going to potentially not get anywhere with these patients. So obviously cardiovascular disease, very important. If patients have an onset of elevated diastolic blood pressure with or without elevated systolic blood pressure, they definitely probably have a situation of diastolic dysfunction, obesity, diabetes, of course, hypothyroidism, sleep apnea, pregnancy. There are some medications and supplements that affect blood pressure, specifically birth control pills, pain medications, some depression, ginsengs, illegal drugs. If patients have issues with their kidneys, such as polycystic kidney disease, or narrowing of the renal arteries, you're going to want to work with nephrology to help manage these patients. We're also looking at specific endocrine issues, Cushing's syndrome, tumors of the adrenal gland. They may have a rare tumor, a pheochromocytoma. This is a tumor found within the adrenal gland. They could possibly have hyperparathyroidism and potentially have coarctation of the aorta. And this is where you're going to see significant different blood pressures in each of the arms. A white coat syndrome, this is definitely something that does exist. I see this quite a bit within the office, and this is why having patients do a 2-week blood pressure log at home is very important. This is a transient rise in blood pressure in the office or hospital setting. It's most likely related to anxiety. Again, this can lead to overestimation of blood pressure and prescribing medications. Again, having patients monitor their blood pressures at home is very important to make sure that you're not just treating white coat syndrome. Malignant hypertension, 1% of patients that you may see may have malignant hypertension. This is when patients present with a systolic blood pressure over 180 and a diastolic over 110. And these patients have evidence of acute target organ damage. They may have neurological changes, cardiovascular changes, and renal changes. This actually gets broken down into hypertensive emergency and hypertensive crisis. These patients need to be referred to the ER immediately. Again, treatment is with IV hypertensive medications, including hydralazine, labetalol, cardipine, and nitroglycerin as an IV. These are patients that you see in the office, and they're complaining of headache, chest pain, significant shortness of breath, and their blood pressures recordings are quite high. If no acute target organ damage, this is diagnosis hypertensive urgency. You can treat these patients on oral hypertensives for 24 to 48 hours, but they need very close outpatient follow-up. We do, in our office, do keep some samples of some antihypertensives, and these patients I may see in the office and give them actual blood pressure medicine in the office, not let them leave and recheck their blood pressure within an hour to see if it's titrating, if it's coming down. So pediatric considerations for blood pressure. Again, we start monitoring blood pressure at the age of 3. Normal blood pressure readings are based on the sex of the child, age, and height. BP ranges consistently in the 95th percentile or greater. is areas where we need to be concerned. This increases their risk of early heart disease and strokes as adults if we don't manage these patients while they are kids. It's somewhat prevalent in 1 to 10%, depending on the geographical areas. Again, if you have a child that you're seeing and they do have elevated blood pressures, we really need to look into possible secondary causes. With these patients, you want to first lower blood pressure by non-pharmacological measures, including weight loss, increase activity, and limiting their sodium intake. For these kids, if you do need to prescribe medications, the first medications that you would start is the thiazide diuretics and the calcium channel blockers and the ARBs. Again, monitoring them very closely. Sodium has a great effect on hypertension. Again, I added a journal article that you can read more about this. Eating salt raises the amount of sodium in your bloodstream and wrecks the delicate balance. It reduces the ability of your kidneys to remove the water. The result is a higher blood pressure due to the extra fluid and extra strain on the kidneys. Again, the World Health Organization, American Heart Association, both strongly recommend reducing dietary salt intake. Patients should have no more than 2,300 milligrams. That's about a teaspoon and a half of salt. Even cutting back 1,000 milligrams of salt in a day can improve blood pressure. The estimated reduction of salt intake by 3 grams per day can lower the blood pressure approximately 5 millimeters of mercury in hypertensive individuals. I will ask patients a lot of times, if you ask patients directly about their salt intake, a lot of people assume that it's just added salt, and they'll make comments that they do not have table salt or use table salt or salt their food. However, there's so much hidden salt in our foods. So I usually have them do a 48-hour diet recall for me so I can point out potentially some of the foods that they eat that actually have higher sodium intake or sodium within them. Just another slide about the DASH diet. The DASH diet is a flexible and balanced eating plan that helps create a heart-healthy eating style. It does not require any special foods. Instead, provides daily and weekly nutritional goals. It includes eating fresh fruits and vegetables and whole grains, including fat-free or low-fat dairy products, increasing fish, poultry, beans, nuts, and vegetable oils. You want to limit foods that are high in saturated fats, such as fatty meats, full-fat dairy products, and tropical oils, such as coconut, palm, and palm kernel and palm oils, and limiting sugar-sweetened beverages and sweets. Some of the changes that we can see specifically with the heart for when patients have hypertension that has not been properly managed is that you will see left ventricular hypertrophy, which is the enlargement and thickening of the walls of the main left ventricle. It's going to be diagnosed via echocardiogram and EKG. I am not going to go through all the case studies, but I do suggest that you look through them and think about what how you would potentially manage these specific patients I've added. So as you are becoming a family nurse practitioner, some important aspects that you should consider is, I think the first thing is doing a very thorough history with your patient. Find out if there's outside stressors. You want to be the cheerleader and motivator for patients to make the lifestyle modifications. Remember to prescribe blood pressure cuffs for your patients. Again, these can be covered by insurance. Give patients specific blood pressure logs. This can just be just a sheet of paper with some lines on it, with some information of how to correctly take a blood pressure. You want to follow these patients very closely, especially when you're starting medications. I usually see the patients back possibly every 2 to 3 weeks for repeat blood pressure checks, and then follow them every 3 to 6 months after that. Sometimes for a blood pressure check, I will actually have our nurses in the office help me with this. The patient will come in and the nurses will check the blood pressure and let me know how it's going, and usually I've documented a specific plan in the chart. Keep in mind the cost of some of these medications. The non-combination medications are quite cheap. You can get them for many times less than $4 or $4 a month or $10 for 3 months. But remember, the combination medications can be very expensive for patients. Again, you want to monitor their lab work frequently. Also, give your patients resources. I've added a couple resources to the module that you may find helpful. And again, know when to refer to cardiology or hypertension specialist.